Good morning, ladies and gentlemen. We start our second session for today. I am privileged to introduce Dr. Mirvat Alasnage from the Kingdom Saudi Arabia to deliver the lecture Intracoronary Imaging to Guide BCI. Just a simple word, in 1998 I worked with Morton Kern in St. Louis. He was working with the FFR at that time. And it helped a lot for many years to guide cardiologists to deploy their stents and to know what critical lesion is. Then, many years later, as a director of Queen Alia Heart Institute, I introduced IVUS, and we asked for OCT later. I don't know if the guys brought it or not, but definitely intracoronary imaging to guide BCI is a very critical and important issue to give better results. Dr. Mirvat, please.
Well, thank you again. Hopefully you won't get bored of me, two talks this morning. So I don't have any relevant disclosures. I'm going to start with a case, and hopefully it'll demonstrate how intracoronary imaging helped us manage this patient. So this was a 62-year-old woman. Her risk factors included diabetes with advanced retinopathy and a vitreous hemorrhage that required laser therapy and was considered legally blind. She also had dyslipidemia and was end-stage renal disease on dialysis. She presented with a non-ST elevation MI, and this is her echocardiogram that you can see. She showed multiple wall motion abnormalities with an overall ejection fraction of 35%. Given her multiple comorbidities, the surgeons deemed her too high risk for CABG. So we went ahead and did an angiogram, and you can see the diagnostic angiogram, quite frightful actually. So what you do see is a distal left main disease, ostial LAD that is subtotally occlusive, disease in the mid-circumflex as well, but what is astonishing here is the amount of calcification that you actually see on fluoroscopy. So we tried to go ahead and IVUS this patient. Unfortunately, the disease was very tight, and the calcification precluded advancing the IVUS catheter. What you can see is a still frame that we caught just as we were trying to advance, and you see significant calcification that is almost 260 degrees or so. So we went ahead and tried OCT, optical coherence tomography. Again, you see the wire, the catheter just slid right in. We ended up doing OCT of both vessels to help us decide if we can, what kind of atherectomy device is necessary for this patient, if at all. So this was the left anterior descending artery. This was the tightest segment where the calcification was approximately 177 degrees. This is automated, so it no longer requires that we as human beings do interpretation. The orange shows you how much calcification, and the OCT showed significant calcification in another segment further downstream over close to 360 degrees. The circumflex, this was the ostium. When you do see some calcification, you do see some disease. Nevertheless, the area was reasonable. We opted to do orbital atherectomy in the LAD to go ahead and optimize the lesion so that it can be, yes, thank you, this sounds louder, to optimize the lesion so that we can deploy a stent. And this was the OCT after a diamondback atherectomy. You can see there's a dissection plane over around 9 to 7 o'clock, but you do see that we have some lumen gain as well. We went ahead and did IVL as well. I'm sorry, this is back frame over here. We were a little concerned that we didn't get enough out of the IVL, and we decided to combine it with enough out of the orbital atherectomy, and went ahead and did shockwave IVL for this patient. And this is what you see in the still frame, and the OCT subsequently with the dissection flap is actually after the IVL. This was the calcium in the mid-segment after orbital atherectomy. The IVL was only applied in the more proximal and ostial segment. And then we went ahead and stented from the left main into the LAD with wire protection of the circumflex, trying to maintain a provisional strategy in this kind of a patient. And this is what we ended up seeing after the OCT done after stent implantation. You can see in the top image that our stent was not well expanded. You can still see the stent struts floating. And then subsequently, we went ahead and did more post-dilatation. You can see that at that point, we had better stent apposition. And this was the final angiographic result and of both the caudal view and cranial view. And you can see in the cranial view, the ostium of the circumflex is well preserved, actually. It's perhaps a little foreshortened in the caudal view. Which takes me to the rest of my presentation over here. What do we get from intracoronary imaging? Well, there is what we call MLD max, which is before the stenting and after the stenting. So before, we want to look at the morphology of the lesion. We want to determine the length of the lesion and find the most appropriate landing zone for our stents. We want to determine the diameter of the stent that we should be implanting. Post-PCI, it's max, where we want to look for medial dissections that require extension of the stented segment, apposition, and expansion of the stent. So when we look over here, what you do see, and I'm just showing you a few examples where we have to get comfortable with imaging and the information that it gives us. What you do see here is a silent ruptured plaque, and this is the arrow pointing to it. It has low risk features because you do not see associated thrombus, you do not see neoatheromas, and etc. What you do see is just an empty cavity, really. So this is obviously something that happened and healed. Macrophages, this is a macrophage. What you do see over here is macrophages are not a good sign. They're a sign of inflammation, ongoing inflammation. And the way you pick them up on OCT is they have a very sharp edges and they're hypoattenuated. But also we look at calcium, right? Just like the case that I just showed you. And you need to be able to distinguish it. So if we go from the right-hand side of the screen, you look at nodular calcification that encroaches on the lumen, to more superficial calcium and then deep calcium, and OCT is particularly helpful for determining the depth of the calcium. Neoatherosclerosis, you see stents in the image number 3 from the right hand, and you see significant neoatherosclerosis. And then calcification, which again here is deep in those two images, and then finally fibrotic and lipidic, and fibrotic is much more bright than the lipidic with some hypoattenuation. With regards to calcium, this is how we determine whether we're going to bring out the big guns, whether you want to use simple balloon angioplasty with a cutting balloon or a angiosculpt, for example, or you want to bring out your rotablator or IVL. So what we do look for is, you see the images where you see some superficial calcium, you see some deep calcium, you see nodular calcium, some of it encroaches on the lumen, some of it does not. But you also see eccentric and more concentric calcium. And what we do want is to determine not only the thickness of the calcium, but the arc of the calcium and the length. So how much length in the vessel is this calcium extending? And I've focused quite a lot on OCT simply because this is a new tool or the new kid around the block, but IVUS is just as good in my opinion. What differentiates is your experience. Ultimately, you need to be able to interpret and get comfortable with an imaging modality. So this is the same patient. You see both IVUS and you see OCT. So this is the OCT showing you the arc of calcium, seeing you the depth of calcium, and this is superficial nodular calcium that's not actually encroaching on the lumen. Again, you see the same thing. This is the nodular calcium by IVUS with hypoattenuation beyond it, and you see the same arc of calcium. So get comfortable with whichever modality you have in your lab, and I would pull out your imaging catheter, particularly for complex procedures. But the next thing is you want to decide, we in our part of the world, diabetes, for example, and pre-diabetes is 40% of the population in the Gulf. So a lot of these patients tend to have diffuse disease. So where do you start and where do you stop, right? Sometimes angiographically it's difficult. What you do want is to pull out, this is an OCT image that actually shows you what is considered green or suitable and what is not suitable. Very often it's not completely normal, but near normal. So you don't want to be, the worst is implanting in a lipidic segment, because these tend to be high risk lesions with high rates of dissections, restenosis, and follow-up PCI is required. Then comes calcification and then fibrosis. So if you need to implant a stent in an unhealthy segment, it's better for it to be fibrous than for it to be fatty, which means you need to be able to distinguish between the different morphologies. Moving on, you do want to determine the size. So what size stent? So there are two mechanisms. You do EEL to EEL. So you're looking at the media to media, for example. But if in the event that you cannot see the media, so you downsize with EEL a quarter size. So if this is a 3.8 EEL, for example, in the proximal segment, what you're going to do is pick a stent that is 3.5, so you'll downsize. If you cannot see it, if you cannot identify the EEL for these patients, then just use the lumen, which was the conventional way of sizing vessels. But in these cases, you don't actually downsize. You may, in fact, upsize just a little bit. And that's the luminal approach. So you look at your distal reference, you look at your proximal segment, and then you decide what you want. Just bear in mind that we usually size to the distal reference, and then we post-dilate to achieve appropriate expansion and apposition in the more proximal segments. And ultimately, this is what you want to do post. So you remember, now you did this for pre, you identified the size and the length of the lesion, but you also determined the morphology. Now post implantation of a stent, you want to look for a dissection. You want to look for a dissection flap that is anything more than 60%, extends beyond the intima, and more than 2 millimeters in length. Those need to be covered and tacked up with a stent. You want to also look at your extension, you want to look at your apposition, and you want to make sure you have adequate stent expansion and apposition. And the minimal stent area is 4.5 for OCT and 5.5 for IVUS, generally speaking. That is what's accepted. Again, some of the automated systems will actually do this, and they will show you in your patients. So you can see over here that the stent struts, they're well expanded and well opposed against the wall. They will automatically give you the percent of expansion, and you'll be able to look at it. This is an example. If you look at the right-hand side over here, the longitudinal image, you see quite a long dissection flap that is extending beyond the stented segment. So again, you want to look at the depth of this flap. Is it extending beyond the intima? Is it more than 2 millimeters, more than 60 degrees, and so on? And this, as you go on, you do see that is actually an extensive dissection that we ought to treat. So I'm going to stop here, but again, my emphasis is, I know that the intracoronary imaging is expensive. It's not available everywhere. So at least be selective and use the catheters when you need them for complex procedures. Perhaps left main, bifurcations, lesions that require atherectomy, and I would say patients who come back with in-stent restenosis. You need to diagnose why they came back with in-stent restenosis. Was your initial stent undersized or underexpanded? Do you have neoatherosclerosis that need to be treated? Is this neoatherosclerosis, does it have a component of calcification that needs further treatment? But in order to be selective, you need to first get comfortable. So I would say start with the simple lesions, get comfortable with interpreting the images, and once you get comfortable with interpreting the images, then you can start using it a little more selectively, and I think that's what worked for me personally. And the main limitation worldwide is, yes, cost, but also operator comfort with interpreting the images and what to do with them. So thank you, and I'm well ahead of time if anybody wants to ask anything.
Welcome again. As you know, the left main stem remain one of the challenging issues in BCI intervention. There are a lot of things and a lot of registry and a lot of trials on left main stem interventions. ABC main, Rolex registry, and so on. So the distinguished speaker today will be Dr. Hussam Suradi. He is well-known interventional cardiologist from USA. Welcome, you are welcome, Dr. Hussam, the floor for you.
Good morning. Thank you for the kind introduction. I would like to thank the organizing committee, specifically Dr. Raed, for the kind invitation. I'm very pleased and privileged to be back here this year again for the PCI Mena. And we're very excited this year that we have this new collaboration between SCI and ICIG, and we're hoping that we'll have more of these webinars and scientific sessions in the future. I'm glad that my talk came after Dr. Mirvat's excellent talks where she covered the bifurcation, stenting, as well as intracoronary imaging. And I'm going to illustrate a case here. Our patient is a 91-year-old who presented to an outside hospital with chest pain. He has past medical history of stroke and seizures, and he was admitted as a case of non-ST elevation MI with elevated troponin. So he was taken to the cath lab, and as you can see here from his diagnostic angiogram, he has a critical, severe distal left main disease that involves the proximal ostial LAD as well as the circumflex with a subtotally or to totally occluded circumflex beyond a large obtuse marginal. And you can see the flow within the LAD was slow TIMI1 or TIMI2 flow. The right coronary artery has also significant disease, mainly involving the proximal PDA. So a balloon pump was inserted, and a patient was transferred to our center, Rush University Medical Center in Chicago. And this is his echocardiogram with contrast, which shows mildly reduced LV function, about 40–45%, with regional wall motion abnormalities in the LAD territory. So as any case of complex coronary disease involving the left main, we involve our heart team approach that involves a cardiac surgeon as well as an interventional cardiologist. And the decision based, given his advanced age and comorbidities, he was deemed to be high risk for surgical intervention, and he was referred for high risk PCI. So as we were planning for this intervention, many considerations came up. Do we need to use hemodynamic support? Do we need to use atherectomy? Is this only calcium, or there's some component of thrombus? And is this going to be a 1 or 2 stent bifurcation technique? So in terms of when we decide whether we want to use hemodynamic support for our cases, we really rely on hemodynamics. We always obtain a right heart catheterization on our patients. And as you can see here, although his hemodynamics are acceptable and they're okay, we elected to proceed with Impella-supported PCI given his advanced age, the critical nature of the left main, the complexity of it, the need of atherectomy, and the large myocardium that is at risk. And most importantly, that there's no really surgical bailout for this patient. If anything goes wrong, this patient is not going to go for surgery or need any more support. So we proceeded with using an Impella CP to support our intervention. As you know, the Impella is a transaxial pump that is inserted in the ventricle that pumps blood from the left ventricle into the ascending aorta, therefore unloading the ventricle. And what we used here is we used what we call a ship technique or single axis technique, where we can use another sheath inside the Impella sheath by puncturing through the diaphragm of the 14 French Impella sheath to put a 7 French sheath so that we can use it as a guide catheter for the intervention. So this saves us from having a secondary access in these cases. And again, this is the Impella device in the ventricle, and again, a couple of diagnostic shots at the beginning of the intervention. And by the way, this is 2 days post presentation. So you can see already the circle is almost occluded and still very slow flow within the LAD. We had really difficult time wiring the LAD. wiring this LED was very challenging. We tried workhorse wires, polymer jacketed wires, Gaia wire. It was really hard to cross it. And really what saved us was using what we call a twin pass catheter, which is a dual lumen microcatheter. So as you can see, there's a wire down the OM, and over this wire, we advanced this dual lumen microcatheter, which has a port at the proximal radiopaque marker that you can see that helped us in angulating the wire towards the side branch, which is the LED. We used the Fielder XT, which is a tapered polymer jacketed wire to wire that LED. Following that, again, due to the question, is this calcium, is that thrombus, and this was too critical to be able to deliver any intracoronary imaging catheter through it, we proceeded with balloon pre-dilatation. And as you can see, there was significant waste at the distal left main ostial LED, and while inflating, the balloon actually ruptured, and you can see the dye going to the LED. So at that point, we decided just to proceed with rotational atherectomy. So the wire was exchanged with a floppy rota wire into the LED, and we used the 175 Rota Pro burr, which we used all the way to the mid-LED. And this was the angiogram following atherectomy, which we have improved blood flow into the LED. And then we were able to pass an IVUS catheter, which, as Dr. Mirvat mentioned, it's essential for these complex left main lesions. And you can see the amount of circumferential calcium, heavy calcium that involves the LED all the way into the left main. And so two things. So basically, you can see the fracture of the calcium here, which basically tells you that we achieved adequate plaque modification here. Another advantage of using the IVUS is the proper sizing of the vessel. So the left main measured about 4.5 as well, and the LED was in the range of 3.5 or so. So we followed that by balloon pre-dilatation. So we ballooned both the LED as well the circumflex. And our decision was to proceed with DK crush bifurcation stenting for this anatomy. So we advanced a Resolute Onyx 2.75 by 22 stent into the OM, and we had a balloon about 3.5, which should be 1:1 sized according to the main vessel, parked in the LED so that we would be ready to crush the stent. So following the deployment of the stent, it's very important to take an angiogram to make sure there's no distal edge dissection beyond the stent. If we're happy with the result, the wire is taken out and then the stent is crushed. And then we recross with another wire. We crossed very easily with a workhorse wire back into the circumflex. And we did our first case with the 3.5 in the LED and 3.0 in the circ. What's interesting about during this time is while the kissing balloon inflation of the left main, the patient lost pulsatility, as you can see from his arterial waveform. And that was one of the advantages of having the Impella. There was adequate perfusion throughout this procedure. And eventually, pulsatility came back with some epi and, of course, deflation of the balloon, the equipments in the left main. Following that, we took a 3.5 by 38 stent all the way from the mid-LED and all the way back to the ostial left main as it was diseased. And importantly, you have to remember to pull your circ wire prior to deploying the LED left main stent. After that, proximal optimization was performed with 4.5 millimeter based on the IVUS sizing, which facilitated wiring the circ again and performing our second case again with a 3.5 in the LED and a 3.0 in the circumflex. Again, repot before you finish to optimize the left main portion of it with a 4.5. This is our final result with excellent angiographic result and TIMI-3 flow in both vessels. Final intravascular ultrasound also showed really well-opposed and well-expanded stent all the way from the LAD into the left main with a minimal stent area of about 16 millimeter, which is more than adequate for this patient. And prior to removing the impella, we start our weaning process by following our hemodynamics. We leave the Swan Ganz catheter in throughout the procedure to check on the hemodynamics. Things that you have to make sure that there's no worsening of hemodynamics prior to removal of the impella. And this patient successfully, we were able to wean him off and take the impella out. And what's amazing was his echo 24 hours after this procedure. So on the left side, this is the pre, and on the right side is the post with complete normalization of his ventricular function, is almost hyperdynamic function. Patient did really well and was discharged home the next day. Thank you very much.
Thank you. Okay, I'll invite our next speaker from Palestine, Dr. Sabri Ghanem. He is going to talk about when treating bifurcation, don't forget the rest. So welcome, Dr. Sabri.
يعطيكم العافية. يمكن هلا كنا مع luxury of imaging from USA and Saudi. Now we are in Palestine. We haven't this luxury of using that. Now we start with a patient of 54 years old. He's a smoker, hypertensive, ischemic heart disease. Previously, he had a stent to RCA. He was admitted as unstable angina. All labs was normal. ECG, poor R-wave progression in the anterior leads. Troponin was slightly positive. And this is the cath. There is many images, but we took the diagnosis of bifurcation LAD diagonal disease. We didn't that ad hoc. We discussed with patient, we discussed the lesion, and we took the decision for doing PCI LAD diagonal. We went by 2-wire, and the plan was to do a provisional stenting, or according to result we complete by inverse crash, kilot, tap as the procedure. This is 2-wire, and then direct stenting to the LAD, and this is what we had of result. This is the left main dissection going down to the stent of the LAD. So if you watch again, before injecting, this was our small erosion of the left main by the tip of the catheter. Just when we injected, after deploying the stent, we had all this. Clear. And this is the dissection went from the left main toward the LAD and the circumflex. So we started first to save the LAD. This is the result. No more circ. Dissected also. This is the LED. Put for the left main. Rewire of the circumflex through the stress of the stent. Report for the left main. Small balloon for the ostium of the circumflex. Good flow for the circumflex. We preferred not to stent the circumflex because the flow was TIMI-3 and the dissection is having all the circumflex to the distality of both the OM and the distal circ. During that, the patient had near collapsed 1 DC shock. So now we have a flow TIMI-3 in the circumflex. We save the LAD and the left main. Then we went back to our main bifurcation. Pre-dilatation of the ostium of the diagonal, still hazy, so we plan to complete the procedure. Stent tap, why tap? Because the less time consuming and to minimize the procedure and to minimize the dye, not because it's the appropriate here. Final kissing. This is our final result. This is the final result we got. Thank you.
Thank you. Our next speaker, Dr. Raed Sabri, is a consultant interventional cardiologist from Ibn Nafis, Iraq. So welcome, Dr. Raed.
Hello, everybody. I'm very glad to be here with my friend in second country in Jordan, and I hope so. This is the first time and will be on annual base. Dr. Mirvat, she was discussing the simplifying the complex, and now we are talking about complicating the complex. My patient, he is a young guy. He has a known case of SLE, presented with ischemic chest pain and positive treatment. For that, he underwent coronary angiography. This is the first procedure. The patient presented with three-vessel disease. There's subtotal occlusion in the proximal part of the LID and subtotal occlusion in the big OM branches. And this is the LID, maybe dissection, maybe thrombus, maybe severely critical lesion. And at that time, the patient referred for CABG and he refused CABG. And he searched for an interventionalist to go for intervention for his coronaries. And this is the first procedure. The operator at that time decided to go for revascularization of the LID. And he stent the LID, and by intention, he decided to put the stent in the ostium of the LID. But inadvertently, the stent pushed to the left mainstem to cover the ostium of the circumflex. And at that time, he lost the OM. There's embolization, and the OM is disappeared. So at that time, he passed a small balloon to inflate the OM, and this was the result. After that, the patient presented to me still complaining from the chest pain. And we kept him on maximum medical treatment, but the patient is still complaining from chest pain. So what is the solution? So after 2 months, we took him to the cath lab, and this was the angiographic result of the patient. The circumflex is totally occluded, and there is unstable lesion in the ostium of the big OM, and the stent covering the ostium of the diseased ostium of circumflex. So at that time, we decided to go for intervention to open this OM. The stent in the LID in the RCA was patent, and there is intermediate lesion in the distal part. So we crossed the proximal struts. We revascularized the circumflex only by PTCA. And the flow was okay, and we didn't decide to put the stent in this small caliber vessel, and we went for the circumflex. We dilate the stent, the proximal strut of the stent, by a small balloon, and we decided to put a stent in the OM. But the stent couldn't cross the proximal stent in the circumflex. So we decided to pull it and generously dilate the ostium of circumflex. But what happened? If you see here, there is something in the circumflex ostium extending to the ostium of left mainstem. We lost our stent in the left mainstem. So what we are going to do? We have lost a stent in very critical position. It is the left mainstem. Shall we retrieve it or deploy it? Retrieving a stent in this situation is very critical because this may disrupt the previous stent deployed in the LID. So at that time, sending the patient, surrender and sending the patient for surgery. So the patient have chest pain and he is in a critical situation. So we decide to go for intervention. First of all, it is clear by stent enhancement that this is the stent extending from the proximal circumflex to the ostium of the left mainstem. So we start crushing of the stent first by balloon in the LID. First, we tried to push a balloon, small balloon behind the stent, but we couldn't. And if you see the previous picture, that the ostium of the circumflex is not healthy. It's diseased. So we crushed the stent first from balloon in the LID and tried to pass another wire into circumflex. Unfortunately, we succeed. We pulled the previous wire and we put another wire. We crushed the stent to the left main stem by balloon in the LID, non-C, bigger balloon, and then we pass small profile balloon into the ostium of the circumflex. Hardly we could pass this balloon, and larger balloon, 1.5, 2.5, and this is an NC balloon, 3 of 12, for generously opening the ostium, and at the same time we try to push this lost stent toward the circumflex. Hopefully we may push it, all of the stent to the circumflex, but we couldn't. Only 2/3 of this stent passed to the circumflex. Now, if you see the distal part of the stent below the proximal circumflex, and to avoid moving the stent, we deployed another stent distally to cover the lesion in the OM and fixing the lost stent by this stent. Here, if you see, we have a healthy left main stem. Now, something happened at the left main stem, and the patient complaining from chest pain and EKG changes. So you have to be rapid. We deploy our stent, and then inflate the ostium of the circ and inflate the proximal part of the stent by the stent balloon. The heaviness is increasing in the left main stem, and now stenting from the circumflex toward this, to the left main stem. This is the iliocranial to localize the stent in the ostium. Here we deploy the stent from left main stem to the circ, and as you see, the ostium of the circumflex is very tight. This is after deployment of the stent, and this is the first spot. This is the sequential kissing. We used NC balloon first for the ostium of the LID, and NC balloon 3.5 for the ostium of the circumflex, going high pressure, and this is the final kissing inflation, and this is the pot, and this is the final result of the patient. This is before the intervention, and this is after the intervention. And the patient continued asymptomatic for the last 6 months. And thanks a lot.
Thank you very much. يعني أعتقد أنه راح يكون في a lot of questions, so may I invite the speakers to the front desks to please answer the questions. تعال. Dr. Rami, Dr. Samer, or Dr. Hussam, please. Or Dr. Mirvat. Let us start with the panelists. أنا بعرف الدكتور يحيى يعني always eager to. If you have any question or comments, please, before we go to the audience.
Thank you very much. I think all the presenters did a good job. At the end, everything went all right. But I think they are very complicated, more complicated in real life than sitting down watching them. Thank you very much, everybody.
Thank you very much, Mr. Chairman. Actually, this is a very nice session with left main stem complication and complex intervention. I have some question, just one question for Dr. Hussam and Dr. Mirvat. do you routinely use the intracoronary imaging in your routine work according to the guidelines of the left main stem, like IVAS, OCT? I mean, every patient with left main stem BCI, you use intracoronary imaging or IVAS, please?
Yeah, I can probably answer by the time the other mic works. Yeah, the guidelines do not really mandate using IVAS, whether for left main or for non-left main. However, there are a lot of data that really supports left main usage of IVAS, making sure you optimize your stent expansion to get the optimal result. In my practice for non-left main PCI, I would say probably I use IVAS 80-90%, especially the highly calcified lesions, lesions that require longer stents, generally more than 28 millimeter. These are the situations where I would use IVAS. Left mains, complex PCIs, use IVAS for all cases. There's an ongoing trial right now in the US that they're looking for IVAS in complex PCI. It's going to be a randomized trial. We're part of this trial, and we'll see what the trial will show eventually. But so far, some randomized data within the, and Dr. Mirvat maybe can talk us more about it. What are the available trials in the non-left main PCIs currently?
Yeah, so I agree with you completely. In our practice, it's pretty much the same. Complex lesions, left main, we try as best as we can to use intracoronary imaging. We don't use it in 100% of our cases. The guidelines lag behind for a reason, that it's not available everywhere and not everybody is in fact using it. More data is coming for IVAS. The ultimate trial is one of the most famous trials that actually did show better outcomes with IVAS-guided PCIs. Although not all of them were left main specifically. There's also the Illumian series for OCTs that are out there. I think the only thing I would add is that I pull out a catheter when I'm in doubt. So when things get complicated amidst a procedure, in the middle of a procedure, and I don't know, like I have no reflow, but I don't know, is it thrombus forming? Is there a dissection flap? Is there something happening? A lot of the times, the time you spend guessing and giving intracoronary drugs to try to see if this is no reflow and it's going to improve, it probably is easier to just put a catheter in, diagnose what's happening, and treat it appropriately. I know this is a luxury and not everyone has it, but if you do have it, I think I highly recommend it when you're confused and you're not sure what's happening.
And if may I add one point before your question, and we all know that there is a better agreement between left main physiology and IVAS. So when it comes to the left main, it's always IVAS or is a better IVAS. When it comes to the rest of the vessels, proximal, distal, OCT has a better result. Dr. Asim Balawi, please.
My question is for Dr. Raed Sabri from Iraq. Your title is When You Complicate the Complex. My question is why you complicate the complex? Why you choose these patients and not send them for the surgeon? And the surgeon will be able to convince them for the surgery. If he fail, then he will let him go back to you. Thank you.
Yes. Thank you for the question. Very good question. I was not the first operator. I was the second operator. And first the patient sent for cabbage and he refused the cabbage. And he underwent the first procedure, not in my country. And the patient returned back to me with single vessel disease to be treated. And unlikely we send the patient for cabbage only for single vessel like OM. Thanks. Mike, I have a question to Dr. Suradi. Dr. Suradi, excuse me, always in the acute setting, your patient was presented acutely and he has a very complex lesion. And usually when in the acute setting, the minimal intervention is intended. Don't you think that you went with rotablator in the presence of respected thrombus burden, a lot of calcium in very elderly patient, and you will increase the risk of no reflow in those subset of patients? Don't you think that using single balloon IVL to inflate the lesion and degrade the calcium and go provisionally with single stent to save the life of the patient and deal with other lesion after that?
Yeah, thank you for the question. This is a great point. I totally agree with you. Complicated cases, try to go simple, and especially tenuous patients, we try to simplify things. In my case, I try to go initially to avoid doing atherectomy, just the concern of having thrombus there and the potential risk of distal embolization and no reflow and so forth. However, the balloon did not expand well and it ruptured. And at that point, shockwave was not available in the US. Actually, US is one of the last countries that where we started having the shockwave available. You guys have the luxury of having IVL here earlier. So at that point, my only option was using atherectomy, and this is the reason why it is. But I totally agree with you. Shockwave is a very reasonable approach prior to proceeding with atherectomy in this case.
تفضل حكيم.
It's the guide who did an erosion on the ceiling of the left main. Just after the dye injection, it induced a dissection toward both vessel of the LED and the circumflex. It was by the tip of the catheter. Why?
Yeah. Dr. Ayman, the guide was roofing and he probably inject hard in the left main. So he dissected the both LED and circ. This is what happens most likely. The guide was long, probably ABU roofing in the left main.
Wasn't coaxial.
It is not coaxial. The most important point in iatrogenic left main stem dissection is the guide. And you see in that film presented by Samir that the guide is not coaxial in its position, and there is no guarantee that the contrast injection will cause the dissection. I think there is some flab from the beginning of the ostia. That's why the dissection become very wide, very big dissection and compromising the flow. So the guide alignment is very important in iatrogenic left main stem dissection, and the most important thing in iatrogenic left main stem dissection is that these cases mostly are preventable. My question to you, Dr. Samir, is the injection is automated injection or you using hand injection? Do you do injection by your hand? No. Or you depend on the nurse or assistant for that?
This is the problem. When we are doing some complex, we have an assistant. In general, it's a technician, and he is not as a doctor as you are doing, and he knows just how to inject. So it's not automated, it's not the same operator. So that's why we always recommend to do the same operator who do the injection, and you know when to do it slowly, when to do it more forcefully. It was done by the lab technician.
Okay, Hakim. Dr. Mustafa, في واحد وراك. أنت next وراك.
Thank you very much. My question for all panelists. As we know in our area, our labs are not much equipped. And in this complex cases, there is a mini cabbage, which is just 3-4 centimeters in between the ribs, and the patient will discharge after 3-4 days. Is it not better that this complex intervention?
And to my opinion, the guideline is a tool and not a rule. And the decision of cabbage not always depend on you. It's the patient decision. And it's for the first time, when you tell the patient about cabbage, the first answer will be no. And sometimes difficult to convince the patient. As this, my patient is an example. No one did the procedure for him in my country, and he went outside to do it. Sometimes you face this type of patient. And to me, I prefer not to send a young guy for cabbage. To put an SVG would be closed maximally after 10 years, and make the cabbage a second for this patient when he develop ISR or stent failure. But the decision of the cabbage is not easy.
I'm in mini cabbage, mid-cap.
Yes.
Mid-cap, all with the arterial graft, Lima L80 and radial, and the patient will go out from the hospital after 3-4 days.
I will answer you, Dr.
We did in our hospital in the last year, more than 100 cases, and actually the success rate is very high, and there is some many minor complication only.
So we lack the evidence that in this region and areas that the priorities for those patients and the result of the cabbage in our local area is still we don't have real data, and because of the I think for the main stem, the Noble and Excel trial, they reverse the things. So to remain that the cabbage is still the solution for some, not most, for some of these diseases in the left main stem and complex coronary intervention. But most of our patients, as our colleagues say, they refuse the cabbage. And we should encourage them, and we do some encouragement or scientific advice through the media and other things. Thank you very much.
Dr. Mustafa.
I'd like to comment on the case of left main catheter-induced left main dissection into LAD and CIRC. I really appreciate the terrific situation you were in, and the observer, of course, is not like the one who is in the field. Really, it's terrific, alarming to have such a dissection, but there is an assuring element here, and we have to take an advantage of it. I am sure that my wires in the true lumen in both vessels. And instead of leaving this circumflex dissected behind me when I leave, I would rather prefer to simultaneously introduce my 2 stents in the CIRC and in the left main to LAD, deploy my circumflex stent to keep the circumflex, and do mini crush or tap technique and finish the procedure to the end, as you know.
Thank you, Dr. Mustafa.
Thank you.
عندنا 2 minutes. أنا بدي أسأل الدكتور حسام. إحنا ما عندنا هنا left impella. يعني أنت questions for you. يعني unloading the ventricle with impella versus no unloadings. في difference على 1 month 6 month mortality ولا إحنا we're just
yeah, that's a great question. Actually, we still lack data about the benefit of Impella high-risk PCI. In the PROTECT 2 trial, where they randomized Impella to balloon pump in these high-risk PCI, there was no significant difference in terms of survival or so. However, at 90 days follow-up, there was a trend towards lower target lesion revascularization within the Impella arm. So really, no
comparison with a simple intra-aortic balloon pump, this right? Or
what's that?
يعني this is comparing it with a
yeah, they compared it with the balloon pump. Right now, there's another. Right, so it's FDA approved. Still, the trial we really don't really have solid data. There's an ongoing trial right now. It's called PROTECT 4, and they're hoping that we can, get more positive results. This is really an area of debate. You can totally do this without high-risk PCI support. However, I mean, in a way, I don't like to take risks. If you saw in my case, there was loss of pulsatility during the PCI. It's always easier in retrospect to say, I wish I used an Impella or some sort of support before the patient crashed. But yeah, we still lack data, just in some.
Thank you. I think we're out of time. Thank you, everybody. We'll move to our next session.